Hi, I am Dr. Selvaraj, your surgical educator, now from Coimbatore, India. So, in this episode, I am going to talk about mind maps. Mainly, it is the importance of mind maps I am going to discuss in this episode. But I will tell you, I have given the title AI Curated Recap. So I am doing this recap in each one of my module in the online surgery course which I am going to launch. So at the end of the each module, I'll be doing what is called recap. So AI curated recap is all it is textual, audio and video also. So this mind map also I will be including where everything about that particular module will be shown. I will show it to you. That is why I am making this video. Okay, I will be talking mainly about the importance of mind maps in any education, not only in medical, surgical, in any education. This is a very powerful tool. So this is the fundamental. Suppose you want to learn something in surgical topic, any topic. So you have to make it as the central point. From that, suppose for example, you want to learn something about acute appendicitis because that is the commonest problem. So acute appendicitis, then you have to tell what is the definition, what is the epidemiology of acute appendicitis, what is the etiology, okay, what is the main cause, and then what is the pathology. Because of this, what happens, what is going wrong in the patient structurally and functionally, and then because of this etiopathogenesis, what clinical features these patients are having. For example, acute appendicitis, mainly they will come with acute right lower quadrant pain. Okay, so that you have to tell. Apart from that, they may have fever and vomiting also, and other signs also you have to tell. The Megmani tenderness, rebound tenderness, guarding, everything. Yeah, all these things you have to fill it up. All this, and then what investigation you will do. Normally, for acute appendicitis, we need not do any investigation, but we are doing investigation to rule out other possibilities or other comorbidities. That you have to know. What are the things you have to know? That also you have to know. Then differential diagnosis for acute appendicitis in a male patient, in a female patient, and in pediatric patient. Suppose the case which you are dealing is a cancer or carcinoma, then you must also know about the staging. After all these things, diagnosis and all, we have to plan the treatment. Okay, and then not only planning, you have to execute it. Majority of our treatment is surgery only. So you have to know how to do surgery. Yeah, especially the postgraduates. Undergraduates, you need not know how to do surgery because majority of you are not going to become surgeons. So mainly the treatment, the execution of treatment, okay, it is only for postgraduate students. Even after treatment, the surgery, some of the patients may develop some complications. So as surgeon, we should know how to deal it. Okay, and then follow up also, especially if it is a cancer patient, patients should come for regular follow up to pick up early secondaries or the recurrence of primary. So this is the format. If you are going to use this format for any topic, it is very easy and it is systematic for you to remember most of the things. The other name for mind map is called concept map. Each and every one of the faculty and the coaching center are talking about concept. But I have never seen anybody is using this mind map in their teaching. I don't know. This is the paradox. I am talking about the Indian scenario. None of them are using mind maps at all. This is a very powerful tool. I am going to show you. So see, because I am very fond of mind map, I started using it even in 1990s while I was working in a hospital in Chennai, Tamil Nadu hospitals. This is a very good hospital it was, but every day we used to have CME between 8 a.m. and 9 a.m. We used to talk. each one of the specialists or the consultants. So, being a pediatric surgeon, okay, I talk few of the pediatric surgery topic. Here you are seeing interception. See, this slide. I made it for OHP, that is overhead projector. I wrote it on a plastic transparent sheet. See, I used different color pens, color coding also for etiology, black color, for types and pathology, red color, history and physical, see, green color, differential diagnosis, again black color, pink color for workup investigation, and pre-op preparation, complications, and management. See, everything is there. Even today, it is applicable. But today, I will show you the evolution of mind map. This is the mind map I prepared in 1990s. Okay, after that, this is another mind map on infantile hypertrophic pyloric stenosis. See, in detail, you can see everything. Everything is there in a single page. That is the beauty of mind map. And this I prepared in 2000, I think somewhere in 2014 when I came to Malaysia, and then I started my YouTube channel then. At that time, using a software called Xmind, I prepared this mind map. So in all of my didactic videos in my YouTube channel, you can see this mind map for each and every, disease. For example, inguinal hernia, okay, I made a mind map. So 1 hour or 35 minutes, 40 minutes video, all the content is covered in this single page. So for the students, after watching and learning from the video and all, yeah, this is very, very powerful tool. Easily you can revise. Whatever you want to revise, quickly you can revise in 5 minutes. You can read inguinal hernia. See, I am covering everything, etiology, what are the special types of hernia, what are the clinical features, complication, treatment, complications after surgery, that is post-op complications. So this is what I was doing even 2 years ago, but now that is what I am going to show you now. Mind maps are very effective in surgical education. It improves retention and recall. It fosters deeper understanding, enhance problem solving skills. I have used mind maps in all my didactic classes. It is a powerful revisions tool, especially to revise it. The another one is, of course, the flashcard. Anki with flashcard and space repetition is also a very important learning, tool. What I am going to show you next is Mega Mindmap. It is not regarding one particular problem, not just inguinal hernia. All hernias I will show you. Not only inguinal hernia in this Mega Mindmap. Femoral hernia, umbilical hernia, incisional hernia, all hernias will be in one single mind map. So one problem I am covering in a single Mega mind map. That is what I am going to show you. Mind is surgeon's most vital instrument. By using mind maps, you are helping students to learn to master it. It's a very important skill. So now I will be going to another. Yeah, this is the mind map. You are seeing this is the another site. I cannot download or share. I can download, but it won't work. That is the thing. See, here you are seeing groin swelling. Okay, all the important subtopics are there. Introduction. Okay, you just click, it will come. So it is a core clinical problem. What are the different causes of groin swelling? Anatomy of the inguinal canal, anatomy of the femoral canal, embryology of the testicular descent, algorithm to clinch the diagnosis. So everything is there in my video, that is also there. This I am going to upload or include as a recap for the students who are going to enroll for my course. So in each, suppose groin swelling is a separate mini course or a module. Each module separately you can go and watch. So after watching all those things, you have to come here. If you want to learn something more, you can click this. It will go to the main page. It will show that particular, what are the different causes of groin swelling, will be shown. Next thing is that only, the causes of groin swelling. See, that is why it was not there. Now you see, it could be inguinal hernia, femoral hernia, undescended testis, the causes for groin swelling. That is why undescended testis, inguinal lymphadenitis, lipoma of the spermatic cord, encysted hydrocele, Sephina varix, femoral artery aneurysm, psoas abscess, femoral nerve neuroma. So it includes exclusively everything. But if you want to learn more about inguinal hernia, you can click here, or inguinal hernia is there separately there also. So we can go there. Anatomy, if you want to learn something about the inguinal canal and what is the anterior relation, posterior, what is the anatomy of the inguinal canal, if you click here, okay, everything will come. Length is 4 centimeter. Superficial inguinal ring is an opening in V-shaped defect, opening in external oblique aponeurosis. What is deep inguinal ring? You just click it. It is U-shaped defect. It is V-shaped. Now it is U-shaped. And the opening is in transversalis fascia. What is the anterior wall? What is the posterior wall? If you click here, it will take inside the main page and it will teach you. Okay? Right. Femoral canal, what is the anatomy? So length is only 2 centimeter. Shape is inverted truncated cone. What are the contents? You can click it. Here also, relationship is very important. Crockett's node, fibrofatty tissue. What is the anterior relation? Everything you must know. But I think it will be there here. What is the anterior boundary, posterior, medial, lateral? It is closed by septum crurae. So if you click this, okay, it will show you what is the posterior boundary. Okay, what is the anterior boundary? Inguinal ligament. What is the medial boundary? Like that, lateral boundary is the vein. Like that, it will show everything. It will show anatomy. Okay, what is the embryology of testicular descent? That is the cause for the hernia. So you must know, even though hernia can also occur in females, but comparatively it is very rare. So the testicular descent is the most important cause for hernia in male patients. So you have to know the testicular descent. What is the primitive gonad development? It is neither testis nor ovary. So you have to just click. Testis is differentiated by a gene in the short arm of the Y chromosome. That gene only will send the signal, then only the primitive gonad will turn into testis. Otherwise, actually the primitive gonad is a ovary. If no signal is going there, it will continue as ovary. Then what are the different hormones secreted by the testis that will dissolve the all female this thing? Transabdominal phase, that is between 8 to 15 weeks. Inguinoscrotal phase, 28 to 35 weeks. So all these things, this is for revision only. You should not come and watch only the mind map. No. I am telling you, you have to read that particular topic. For example, groin swelling. So I usually, my teaching, you can go and see. Okay, I will teach inguinal hernia, but inguinal hernia comes under what problem? The main problem is groin swelling. So many causes I told you. Each and everything could be a cause for the groin swelling. It need not be a hernia at all. It could be a inguinal lymphadenitis. So you should know how to differentiate. The moment you are seeing a swelling in the groin area, like a swelling in the neck where you are asking the patient to swallow, here you have to ask the patient to cough. If there is cough impulse is there, it is hernia. If cough impulse is not there, okay, it is not at all hernia. Very easy. So, but you should know what to do. So, inguinal hernia, if you want to learn elaborately, just click inguinal hernia. See, what is the definition? A clinical vignette which I have said in my video, it is there. If you click, it will take to the main page. You can see that vignette also. What is the etiology? Pediatric is congenital because of persistent processes vaginalis. Indirect hernia is because of increased intra-abdominal pressure. Direct hernia is because of the weakness of the posterior wall. See, it's very classification is not important. Indirect inguinal hernia, you just click it. Hernia is through the deep ring. What are the coverings? What are the types? Indirect inguinal hernia. bubonocoele. Three types. Bubonocoele means it is in the groin itself. It does not come out of the external ring. Funicular, it has come out of the external ring and just stop just above the testis, that is funicular. Complete scrotal is congenital, where you cannot feel the testis separately. See, what are the clinical features of inguinal hernia? Okay, you just click it. Swelling in the inguinal region, dragging pain, expansile cough impulse. Shape is pyriform if it is indirect, globular if it is direct. Reducibility, normally it should be reduced. Deep inguinal ring occlusion test is positive if it is indirect inguinal hernia. G means 3-finger test, and you have to examine the respiratory system to rule out any chronic infection with cough. Leg raising test, you can rule out the R head raising test also. Malgagnis bulge, which is a precursor for the direct hernia in aged or elderly patient. What are the special types of hernia? Invariably, they will ask one MCQ from the special varieties of hernia. They are dual pantaloon or saddle hernia, sliding hernia, Richter's hernia, Madel's hernia, Littry's hernia, Amiens hernia. Amiens hernia means appendix is the content of the hernia, that is amiens. So you must know all these things. What are the complications of hernia? Irreducibility. It could be obstructed. It could be strangulated. It could be incarcerated and reduction en masse. These are the 5 complications for any hernia. But you should know few things. Obstructed hernia can happen only if it is omentocele. Sorry, only if it is enterocele. If it is omentocele, it cannot undergo obstruction. This you have to, but it can go for strangulation. Yeah, omentum can go for strangulation, but not obstruction because there is no lumen in the omentum. And you should know the difference between irreducible hernia and incarcerated hernia. Irreducible means the problem is in the internal ring, which is very tight. That is why you couldn't reduce the hernia. Whereas incarceration, the deep ring is okay, normal. But this is a chronic hernia. Chronic may be omentocele or even enterocele. There will be development of adhesion between the sac of the hernia and the content. So because of these adhesions, you cannot reduce the hernia. This is one thing. Or the fecal matter inside will get solidified and that will obstruct the hernia. These are the 2 causes for incarceration. And then reduction en masse is, if you are trying to reduce the hernia, that is called taxis. If you are using your force and reducing it, the whole thing won't get normal reduction. It will go for what is called reduction en masse, which is nothing but the invagination of the whole sac with its content. Yeah, that is also one of the complications. Then coming to the treatment, you just click it. Pediatric hernia is congenital, treatment is herniotomy. Young adult, the treatment is herniorrhaphy, and old people, elderly, hernioplasty. But nowadays, we are doing hernioplasty for everybody. Herniorrhaphy, there are few types. Bessinis repair, Soltis, Melonis repair. Okay, this is also Desdada repair, external oblique aponeurosis. All these things you can go and, watch my video and you can learn. Yeah, in the inguinal hernia video. Old people always, not only old, everybody we are doing this only. And this is called Lichtenstein's tension-free mesh repair, open repair. Prolin hernia system is also there. Open pre-peritoneal or Stoppa's repair also is hernioplasty or laparoscopic repair. When will you do laparoscopic surgery? Nowadays, there is no restriction. They are doing for everybody. Even the first timer or the fresh, hernia patient, they are doing laparoscopy or even robotic they are doing. But the real medical indication is 2 things only. Indications, okay? That is bilateral inguinal hernia and recurrent inguinal hernia. There are 2 techniques, okay? TAP, transabdominal preperitoneal technique, where you will be entering into the peritoneal cavity and repairing it. Here, the TEP, totally extraperitoneal repair. So both you must, but nowadays you must know all these things. In my days, there was no, there was no laparoscopy. Only after 1989 it came. So what are the complications of the hernia? This surgery, post-op complication, seroma, hematoma, urinary retention. Recurrence was there in pre-mesh era. Nowadays, the commonest complication is nerve entrapment neuropathy, which is resulting in chronic neurologic pain. While you are taking bite to fix the mesh into the inguinal ligament or conjoint tendon, you shouldn't include two of the nerves which are there in the inguinal canal, namely the ilioinguinal nerve and genital branch of genitofemoral nerve. If you are going to include them accidentally, then these patients post-operatively will be having chronic neurologic pain. This is what is called nerve entrapment neuropathy. So this you can treat symptomatically. And then you have to be very careful if you are compromising or destroying or injuring any of the blood supply to the testis, it will go for testicular atrophy. So see, you have gone through, this is only inguinal hernia. If you want to learn femoral hernia, you click that one. See, definition, clinical vignette, everything is coming. Etiology, you click here, you will learn about this one, clinical features, types, treatment, complication. You just click here, you can see that one. I'm not going into the detail because this is not a teaching video for the groin swellings. I just want to show the importance of mind map. And this is called Mega Mindmap. I have already made, mind maps for separately for inguinal hernia, femoral hernia, ventral hernia, that is incisional hernia, and the undescended testes also I have made. All are separate mind maps. Here, this is Mega Mind Map. See, you can just click it. You can see what are the different types of ventral hernia. So many are there. Epigastric hernia, you click it, you will learn everything about epigastric hernia. All are called ventral hernias. Epigastric, umbilical, incisional, spigelian and lumbar. So if you want to know something about incisional hernia, because this is the commonest among ventral hernia, you just click here. Yeah, definition, hernia through acquired scar. Scar hernia, otherwise. That is what is called incisional hernia. It's very common in females. Contents could be either bowel or omentum. What are the precipitating factors? Click it. Poor surgical technique. This is surgeon's fault. Post-operative complication, infection, cough, patient factor. General factor, patient is anemic, diabetes, steroid, all are, this is also patient factor. Tissue failure, okay, abnormal collagen production. All these are precipitating factors. What are the clinical features in incisional hernia? History of previous surgery or could be even trauma. Age, it can occur in any age, more common in elderly females. Symptoms, swelling and pain, rarely obstruction. Signs, expansile cough impulse, reducible, defect through the scar. You can feel the defect through the scar. Type 1 is midline, wide defect, reducible, low strangulation risk. Type 1 of incisional hernia. Type 2 incisional hernia is lateral, higher, a narrow neck, and then risk of strangulation. So what is the treatment for each one of this one? For incisional hernia, you just click it, conservative. What is the operative treatment? What is sublay mesh repair or IPOM? And rarely, if it is a complicated, very big incisional hernia, you can go for what is called component separation. So you are learning each and every fact without failure easily. Like a game you can play and learn. That is why I am telling it is very, very powerful technique. But I don't know why nobody is using it properly. Yeah, lumbar hernia, you click it, okay, you can learn about all these things. So click here, it will go down. And child with an empty scrotum, this is nothing but your undescended testis. What is the objective? What are the different causes? Okay. If there is no testis in the scrotum in a child, male child, of course. So it could be an undescended testis proper, it could be a ectopic testis, it could be a retractile testis, or post-tarsal atrophy or anarchia. So you have to know. I have talked about all these things in my video on undescended testis. You go and watch. And I told about the embryology of testicular descent and the classification of cryptorchidism. What is undescended testis? What is ectopic testis? What is retractile testis? Everything is there in detail. If you click it, retractile testis is very important. Actually, retractile testis is a normally descended testis. You can manipulate it into the scrotum by doing what is called a milking maneuver. Actually, the testis is pulled up by the overactive cremasteric muscle. While the child is sleeping or relaxed, it will descend down into the scrotum and it will descend down into the scrotum by puberty. So you need not do anything, just reassurance. That is why you should be able to differentiate retractile testis from other causes. That is why it is very important. And what is the take-home message? Operate between 6 months to 1 year. All undescended testes should be operated. Don't tell that you can get operated after 4 years, 5 years, 6 years, nothing. Should be operated between 6 months to 1 year. Delay in surgery carries risk of infertility and malignancy also. Hormone therapy, you can try between 3 to 6 months of age. Up to 3 months, you can wait and see. There is a chance for spontaneous descent. Retractile testis should not be operated. Intra-abdominal testis best managed with laparoscopy. See, everything is there. Quickly you can revise. Now you see the whole thing we have covered. We have covered everything. You can, if you want to learn any particular thing only you want to learn about only ventral hernia, you can go click this part and you can learn. So this is a very effective method of learning the any topic. Yeah. And thank you very much for listening this. And I hope that you will start using mind maps extensively in your reading. And you yourself, I am talking to all my students. You yourself can go and create this one from this website. From this website, that is Notebook LM from Google. Go and you can create this one. That's a very powerful learning tool, this Notebook LM. Please, you can do it. And thank you very much for listening this, the video.